thank you all for joining us this evening. I'd like to discuss, first of all, a little bit about SPECT-CT, how it works, and the technical side of things. And then Dr. MacArthur will be joining us a bit later on to discuss some case studies that might interest you and show you how that you can best serve your patients. So first of all, we just want to discuss a little bit about nuclear medicine. Nuclear medicine is a modality of medical imaging where we look at the physiology of the body. So instead of anatomy, which is mainly served by CT and MRI and general X-ray, we look at physiology, how things function in the body. We do this by injecting a radiopharmaceutical. That is a normal chemical that's found in the body that is labelled or tagged to a radioisotope. And that radioisotope gives off gamma rays, which we detect with our cameras. These radiopharmaceuticals allow us to visualise the passage of the pharmaceutical through the body, such as through the perfusion of an organ or the transit of food through the gut. So we're basically taking advantage of normal physiological processes that happen in the body, and we're just watching them as they happen. So those things can take, we sort of rely on the time it takes for those processes to occur, and that's why a lot of nuclear medicine studies take a lot longer than you would normally think. So we can also watch these pharmaceuticals taking part in these functions, such as the osteoblastic clastic reactions in the bone, which is mainly how our bone agents work. Or we also take advantage of the phagocytosis process, where we inject labeled colloids into the body and allow the phagocytosis to proceed, and that sends this pharmaceutical to areas of the body such as lymph nodes or the liver or the bone marrow. So SPECT stands for Single Photon Emission Computed Tomography. Single photon emission part is pretty straightforward. That's the gamma rays that are emitted by our isotopes. It's obviously computed, everything's computed these days, and the tomography means that the camera moves in a 360-degree arc around the body. It was first developed by Kuhl and Edwards in 1963 as a means to perform 3D imaging of a patient, and that so they could separate out different structures within the body. A series of images are required as the detector moves slowly around the body in a step and shoot fashion. And as the detector rotates, it collects the gamma rays coming from the patient and forms an image. So the gamma rays appear as a single dot on the screen. We obviously collect thousands and thousands of those dots. And the more of those dots or counts that we collect, the better images we get. And that means basically we get increased spatial resolution. And spatial resolution is how small an object we can see. And in nuclear medicine, we're probably looking at the smallest object we can see is about 12 to 15 millimetres. This is just an image of the very first SPECT-CT machine that was produced back in 1968. And as you can see here, they've got two single detectors rotating around this poor patient, around her head. They do get very, very close, and I don't think I'd really want to be in there. And these are the sorts of images they produced. So very poor from our standards, but from their point of view, they thought that this was a tumour in the brain, and they diagnosed and treated people based on these images back in the 60s and 70s. So what does your patient experience? Well, essentially they lie still for about 10 to 12 minutes as these detectors rotate around the body. They have a proximity sensor on the cameras, so they do get very close, usually within 2 to 3 centimetres of the patient, and it follows the body contour as they move around. So they really do stay extremely close, and that is to ensure that we collect as many gamma rays as possible and get the best quality images that we can. Unfortunately, this can create a sense of claustrophobia for the patients, and we do have some ways to manage that, which I'll discuss a little bit later. The detectors then move out, and when they've completed their full 360-degree arc, and then the patient bed slides into the CT gantry, which is at the rear of the machine, and we do approximately a 1 to 2 minute acquisition under the CT. We obviously do exactly the same area of the body that we did the SPECT on, and it's very important that the patient does not move between those two scans so that we can fuse the images correctly. At the end of that acquisition, the images are reconstructed with the computer and typically sliced into 3 of the anatomical planes, standard anatomical planes. So this is just a little movie of a SPECT-CT in action. So these are the detectors that you can see above and below. The patient is the pillow, if you can imagine that. And it slowly moves around. This is going at a much faster pace than it normally would, but it moves very slowly around. It follows the contour of the patient closely, as you can see. It does, and because we have the 2 detectors, the camera only needs to move 180 degrees, but it will acquire the full 360. So as it comes up to the top here, you will see the detectors move away in a moment, and then the patient, pillow, move into the CT gantry. Just going to take another few seconds. So there's the detectors moving away, and then the bed will automatically move into the CT gantry at the back and then perform a scan of that patient. And we communicate with the patient to keep very still while the bed is moving, because quite often they do move around a little bit. And this is just a little bit of technical explanation, so please don't fall asleep. I know it's a little bit too much for a Thursday night, but essentially this is our patient here lying on the bed. The gamma rays are coming from the patient and hitting a crystal. This is a sodium iodide crystal, and it covers the entire surface of the camera. So that's a representation here of the gamma ray coming in, hitting the crystal. The crystal then converts the gamma ray into a photoelectron, which then passes through this photocathode here, and that converts it into an electron beam. It's a very small electron beam at the beginning, and then it passes through all of these diodes to increase the signal, and finally it ends up as a current which appears as one dot on a screen. We collect millions and millions of these dots to provide a really good image, and what we get now of the brain is something along the lines of the picture below, and this is a Ceratec study that was done recently, and obviously shows much better resolution inside the brain. And these are our typical images. So these are the 3 anatomical planes that we slice the images into. These are our SPECT images on the top line here, and below our SPECT CT. So we usually use our coronal, transverse and sagittal planes, but we can actually slice in any direction if there's something unusual that we need to look at. Now, the main advantages of using SPECT-CT, the first one is attenuation correction. So just a little bit of an explanation about attenuation. So attenuation is when gamma rays are absorbed by dense objects within the body, such as bone, muscle and fat, and therefore they can't exit the body to hit the detectors. So they're basically absorbed inside. And those gamma rays are lost to us. We can't see them. So therefore, what happens is the computer uses the data from the CT scan and calculates the density of each pixel and makes an attenuation map, which allows us to correct the gamma rays hitting the area, and allows us to see structures that were previously masked. So I'll just show you a really good example of this. So this is a myocardial perfusion study. So this is the perfusion inside the myocardium. As you can see here, the inferior wall of the heart looks very patchy. And if you didn't realise that this was attenuation, you may have called that abnormal. But in particularly males, their diaphragm can be quite dense. And so it can attenuate a lot of the gamma rays coming from the inferior wall. So what we use our attenuation correction for now is to better understand the gamma rays coming from the inferior wall of the heart, essentially as an artifact. And so now that looks completely normal, that inferior wall. So this is now something that allows us to image patients who might have a large body habitus, or males have a very heavy diaphragm for myocardial perfusion studies, and also many other things that benefit from attenuation correction. So this is a little bit about image fusion. So this is when we lay the CT scan on top of the nuclear medicine images, which allows us to see both the physiology and the anatomy on the same image. So first of all, we have the CT scan. This is obviously a patient's hip replacement. The query was query loosening for this patient. We then create the attenuation map. And then on top of that, we lay the nuclear medicine image. And you can see clearly here that there's a hot spot here at the proximal end of the stem, and also at the distal tip, which would indicate loosening. So if you remember the CT image before, you may not have realised that that was becoming loose. But when you lay the nuclear medicine image over the top, you can see that clearly there's some abnormalities there. And that's just a bit of an explanation of what we're seeing. So just for your information, the CT component of the SPECT-CT is a non-diagnostic scan. So if it's really only there to provide that attenuation correction and that anatomic localization. If you would like a separate diagnostic CT, if you could please specify that on the request and we will arrange it. We don't usually provide a separate CT report unless there's a specific reason to. And we don't usually use IV contrast with our SPECT-CT work. So we actually treat it very differently. There are some challenges associated with SPECT-CT. The first of all is patient movement. So that's the movement during the SPECT, because that does go for about 10 or 12 minutes and people who are in pain can get uncomfortable and move. And then also the movement between the SPECT and the CT scan. So we have to make sure that they're very still. The best way to ensure that is to make sure they're comfortable, speak to them clearly about the requirements of the scan, that they need to keep still. And we also, at the very, if we need to, we do have programs, computer programs that will correct for movement if it happens. So, you know, we do have that as an end result if we need to use it. The other one is claustrophobia. As I mentioned before, the cameras do get very close to the patient. And in most circumstances, the patients actually cope with that really well. But occasionally, we do have some very nervous people under there. So again, good communication is key. They can have a friend or a partner sit with them during the SPECT scan, and we ask them to leave for that final CT scan because X-rays are produced. So it's just that last minute that they need to be on their own in the room. If they don't have a friend with them, we can sit with them and talk to them and help them get through it. We can use eye masks or earbuds. They can listen to a podcast or some music on the phone. Or in the very last resort, we can ask their GPs or referring doctors to supply some oral sedation that we can give them prior to their scan, but we just must ensure that they're getting a lift home after that. The cost component of the SPECT-CT, so it is fully Medicare rebatable. It is about $95, but in most instances, this does not increase the out-of-pocket cost for the patient. And finally, just a few words on radiation dose, because I know you will get quite a lot of questions about radiation dose from your patients. So just a little bit of information about how we measure radiation dose. So it's usually measured in CVITs, which is a measure of absorbed dose in a human being. Typical doses for X-ray procedures are the CT chest abdo pelvis gives us about 8 to 9 millisieverts. A CT in nuclear medicine, so the SPECT CT, the CT component of a SPECT CT is about 2 millisieverts. So it's about 25% of a standard CT scan. Bone scans about 6 to 7. VQ scans or thyroids about 3 millisieverts. The cardiac perfusion studies, the MIBI scans or thallium scans, as you remember them, are about 12, so a little bit bigger. And the parathyroids are about 7. So just to put this in a little bit of perspective, we all receive about 2 millisieverts per year from just living in Melbourne, just from background radiation. So that's approximately the same as the CT component of a SPECT CT. It's about living for 1 year in Melbourne. If any of you have granite benchtops at home, that gives off radon gas, and you will receive about a millisievert per year from your granite benchtops. And even eating a banana actually gives you a little bit of radiation as well, just so you know. Okay, I'm going to pass over now to Dr. MacArthur to discuss some ways where SPECT CT could be useful for your patients.
Thanks, Holly. Thanks everyone for coming. I'm just going to run through a few, I guess, clinical indication side of things and a few cases. And then I think probably we'll have a chance to have a chat and get some questions in at the end as well, if you would like. So the main role, I guess, in SPECT CT is in the anatomical localization of abnormalities that we're seeing on the nuclear medicine bone scan or any nuclear medicine study, and also applying better spatial resolution to planar imaging. We've got some good examples there. So, for instance, myocardial perfusion scans for ischemic heart disease. We've routinely done SPECT, and we've done SPECT as part of myocardial perfusion scans for many years. But the additional of the CT component is particularly useful for attenuation correction, as we saw in that earlier example where that inferior wall of the heart was not well seen on the non-attenuated maps, and then post-attenuation correction, that inferior wall came back. With biliary and liver imaging, we are now using SPECT CT, particularly within the hospital setting, for things like biliary obstruction in patients, for GI bleeding. We've always done planar imaging, but the addition of SPECT CT helps us better localize that to small or large bowel, or even sort of locations within those structures, which helps sort of the surgeons and interventional doctors better localize where they're going to go and where they have to look for the bleeding. The lumbar spine, or in general the bone scan, is probably the most obvious utility for SPECT CT, and is certainly where we would use it the most, and probably in the general practice setting would be where you guys will be thinking about it as well the most. And it just adds a whole level of I guess certainty to the planar, compared to a planar bone scan. As you can imagine, if you're looking at a lumbar spine from back to front in a sort of standard kind of planar fashion, there's a whole heap of structures within that could potentially be causing pain. You've got, disc spaces, you've got end plates, you've got facets, you've got uncovertible joints in the neck. And so all of those things can be pain generators, and it can be very hard on planar imaging to tease which exact structure is causing the problem, and this just gives us a bit more diagnostic certainty. And I guess that comes down to also reduce false negative rates, and that's particularly, I guess, in the larger patient. Holly had talked earlier about how the gamma rays have to escape the patient for us to detect them, and obviously the deeper you are, the less likely, or the harder it is for those gamma rays to get out. And so the SPECT CT increases our diagnostic sensitivity by allowing us to basically be more sensitive to those deeper structures. So here's some examples of where we would be useful. We've covered some of these already. Small bones in the hands and feet. Again, you can imagine on planar imaging, if we're just looking at one side or the other of the foot, even if we sort of take a number of different look at the feet in a number of different planes, so from the bottom or from the front or from the side, there's a lot of overlapping structures there, and foot pain obviously can be multifactorial as well, and so allowing us to better localize where exactly those what joints, particularly good for things like subtalar joints, the intertarsal or tarsometatarsal articulations, which can be quite difficult to sort of fully localize on planar imaging. The vertebra, as I discussed earlier, help teasing out uncovertebral versus facet versus end plate uptake. The loosening of prostheses, we do a lot of SPECT-CT for the orthopedics guys, for hips and knees particularly, looking for loosening in patients who have got total knee or total hip prostheses. Not super useful in the sort of I guess in the 1 to 2 years after a replacement, because there's a general osseous integration, which will be hot on bone scan, but more useful, particularly in that sort of 2 to 3 year mark, if you've got a patient who has had a joint replacement and then was fine, but now maybe beginning some worsening pain around the replacement or in the affected side, to look at that. So yeah, particularly useful, I guess, in that kind of 2 to 3 year mark out for loosening, although it can be helpful for exclusion of infection and sort of, I guess, the more sort of subacute setting. Probably, I don't know how many of you would be looking at parathyroid imaging. But the parathyroids are little tiny glands, and often they're very difficult to see. And unfortunately, the thyroid lies over top of them, and that can also have quite a lot of uptake in it as well. And so using a SPECT-CT helps us sort of localize what is thyroid, what is not thyroid in that setting as well. A few other things that sort of thinking of just off the as well. VQ scans, we routinely use SPECT as part of VQ these days, but the addition of SPECT CT and VQ scans is particularly useful. And this allows sort of a better evaluation of underlying parenchymal disease, which can be kind of a confounding factor. So particularly patients with shortness of breath and with known interstitial lung disease or COPD or things like that, it just helps us be a little bit more sensitive in regards to, oh, here we've got a perfusion defect, it's partly matched on the ventilation. Could this be related to a chronic PE, or could it be related to the underlying lung disease? And by doing a CT as a component to that, you can say, oh, look, this is an area of atelectasis, or this is an area of severe emphysematous change, or something along those lines, which just helps you kind of give a more accurate report, as opposed to saying something like, oh, this is an indeterminate VQ scan, which is not particularly helpful from a referrer's point of view. Like, what do we do with that in that sense? So I went through a few case studies. A few of these have been of sort of general cases, and then the last few are specific bone scan cases and some discussions in regarding the utility of SPECT-CT. Our first case is a myocardial perfusion scan with a guy with a multivessel ischemia. He's a 62-year-old bloke who's presented with exertional shortness of breath. He's had previous stents in the past. He's got a pretty significant sort of history. All the risk factors: hypertension, hypercholesterol, type 2 diabetes, smoking, and a family history. He's basically got a lay down misere of myocardial ischemia and likely underlying disease. In patients who are quite large, we often do a 2-day protocol, and the reason for that is we sort of have an upper limit of how much radiotracer we want to give in a day, and if patients hit a certain threshold, we like to sort of stick it in 2 days to allow us to give sort of be as diagnostic as possible. If you give a small amount of the radiotracer is largely weight based, and so if you underdose the patients with in that setting, quite often the images aren't that good. So we like to split it up into 2 days in patients who are, you know, sort of hitting that 120 kilo mark or over. He had an adenosine stress test with some low-level exercise. He's had a great response there, 157 heart rate, which would be sort of probably his, you know, reaches 85% maximal heart rate even as part of stress. Here we go, resting sinus tachycardia of 131 BPM. That's probably not that great either. And his stress test was ceased due to angina, although we run a standard 4-minute protocol for adenosine. Most people will be all right with that. There can be some, they can get quite a lot of symptoms with an adenosine stress, but as I say, it only goes for 4 minutes, and so most people tolerate it, even if they do get sort of quite significant chest discomfort. So the main things people will say with an adenosine stress test is they'll get this sort of heaviness in the chest, shortness of breath, and a headache. So the sort of cardinal signs, and flushing as well. They get and it's all related to vasodilation. So here we go. Now, this is quite small on my screen, so I'm going to get a little bit close, but here we've got the resting imaging at the bottom and the stress imaging at the top. And here's this area of myocardial perfusion reduction in the mid to distal anterior wall of the left ventricle. And here's the resting imaging, which shows that this area completely recovers. So this would be a recovery of this area, which is consistent with a LAD territory ischemia. And then more significantly, as opposed to not just related to this, you can actually see he's got this, what they call transischemic dilatation, which might be a word that you remember from back in your cardiology, physiology days. But basically when the myocardium becomes ischemic, significantly so, it will start to dilate as it can no longer as the function drops off. And here this is seen as LVF drop from 77% at rest to 30% at stress, and this would be suggestive of, you know, quite severe triple vessel disease. Here was a CT bar that was done as part of a SPECT-CT. So we, as Holly's mentioned before, we always do a CT scan for attenuation correction purposes, and you can see this chap's got very severe coronary vascular calcification, which all goes in with his underlying diagnosis. Here's a 72-year-old lady with a sclerotic area in the L3. She had severe back pain and had a lesion in the L3 vertebral body on CT. And the question was whether she had other metastatic disease or another cause for her back pain. So we might just skip ahead to the pictures and then we'll come back. So here we are. Here's this lesion in the mid aspect of the lumbar spine. And here on the fused imaging, you can see there's normal physiologic marrow activity, but she's got absolutely no significant increased uptake above the background physiological uptake within that lesion. But as we come down, we can see here we are, her right L5-S1 facet is absolutely screaming hot. And this would be most likely the cause of her back pain. And the good news for her is that she's got no other lesions in her spine. And so this would be a benign bone island and her likely facet arthropathy causing her pain. Just to confirm that. Might go on again, we've got a few more bone scans to look through. There you go. So here's a man with a calcaneal fracture 12 months after a fall, had an internal fixation but ongoing foot pain. They were looking for loosening or non-union. And here's a scan showing that there's absolutely no uptake around his screw. So there's no features of loosening. But if, we've got a play button. Oh, here we go. This is going to be exciting for everybody. It's going to work. Might take a minute. Technology. That's supposed to scroll for you. Anyway, but here we can see that what he hasn't got any features of non-union, but he has got uptake in that posterior facet of his subtalar joint. So after his fracture, he's probably developing some inflammatory changes and early arthritis within his subtalar articulation, which is the cause of his pain. We can target this again with steroid injection to help as a diagnostic and I guess therapeutic tool to help alleviate the patient's symptoms, but also prove that that is the side of it, that is his pain generator. Let's try that again, see if it'll work. Computer says no, sorry. So here's a man, a 75-year-old with undifferentiated neck and back pain. He's had chronic neck and back pain for many years. He's got reduced right lateral rotation, and there was a suspicion for facet arthropathy in this patient. And so a CT scan was ordered for him. And I guess this is an example about of where maybe a SPECT CT would have been a better diagnostic tool in this patient. So the referring doctor was already suspicious that the man had facet arthropathy. And so he's had a CT scan, and here's his L5S1 facets, his L4 5 facets, and his L3 4 facets. So he's got bilateral facet joint disease, but it doesn't tell you anything about what potentially is causing his pain, whether any one of those facets is a pain generator. It doesn't help you target whether the diagnostic / therapeutic injection. And so all you've done essentially is proven the fact that you knew he had facet joint disease from a clinical examination. He's got a CT which proves he's got facet joint disease, but you're really no better off from a clinical perspective about how you're going to go about treating this guy. So in this case, SPECT CT probably would have been a better tool. You already had a high clinical suspicion that the man had facet arthropathy, and so what you're doing now is by doing the SPECT CT, you get to prove that he's got facet joint disease because you're doing a CT as part of his examination. And yes, it's not a diagnostic CT, but it does give you enough information about whether there is or is not facet arthropathy, but also the SPECT component of that examination would then show you which facets potentially were the hot facets or the most active sites of disease, which would then help you localize his pain a bit better and help target an injection. Here we have an 82-year-old man with ongoing shoulder and back pain. He's got a long history of seronegative inflammatory arthritis. He's got known polymyalgia rheumatica, currently on prednisolone, and he presents with persistent lumbar and shoulder pain. And the clinical question is, has he got active inflammatory arthropathy as a cause of his pain? Has he got degenerative disease? And what are his pain generators? So this is a two-phase bone scan. This is planar imaging. And we use a two-phase bone scan to help us tease out sites of particularly active disease or sites with associated inflammation. And on this scan, you can see that this man has got, it's often easier to work backwards for a two-phase scan. So you're having a look at the delayed imaging, which is this one here, which looks like the skeleton, finding the hot spots, and then working back to see whether they have an associated uptake on the bones, on the blood pool imaging, which is this scan here. So here you can see he's got some sternoclavicular uptake on the right, and yes, he's got some blood pool activity in this, suggesting that there is an inflammatory component to that joint. In his back, you can see that he's got some uptake in his lumbar spine, which is a bit difficult to say exactly where's this facet, is it within the disc spaces, but if you follow this lower left-sided uptake backwards, you can see that on here there's a little bit of activity here as well, suggested that there's an inflammatory component. And I guess in this particular setting, the other important thing to note is that if you have a look at his large joints, his shoulders, his elbows, his hips, his knees, and around the sort of ischial tuberosities and pelvis, there's no inflammatory related synovitis to suggest that his PMR is particularly active at the moment. So the bone scan suggesting, look, you've got him on prednisolone. He hasn't got a hell of a lot of active large joint pathology that would explain. It will suggest that his PMR sort of being relatively well controlled, and that his pain is probably not related to his PMR. But what is causing his pain in the setting? So here we can see. Let's have a look. There we go. So if we have a look again at his planar imaging, scroll back. We're trying to tease out where exactly all this is coming from. So we look at the coronal imaging and we can see he's got some end plate uptake, which probably explains part of it. But then we have a look at his sagittal and axial imaging, and you can see that he's got quite marked uptake in relation to that facet joint, which is likely the cause of his back pain. Although we didn't inspect his thorax, you can see that the sternoclavicular joint is hot and also has some inflammatory component to it. So in this setting, you'd be pretty suspicious that maybe his right shoulder pain is referred pain from his sternoclavicular joint. And again, you know, this helps you target with ultrasound and maybe a steroid injection into the sternoclavicular joint, seeing if that would help reduce his shoulder pain. So a bone scan in this setting is a great tool for kind of just generally looking at what's happening with a patient and helping target sites for sort of further evaluation and investigation. Here we've got a 53-year-old lady with right hip pain, and she's got fibromyalgia. She had a fall onto her right side in 2022. She's got ongoing pain in the hip after the fall. She's 122 kilos. And if we have a look at her planar imaging, you can see that she's got a bit of knee joint uptake, a bit of ankle uptake as well. So she's got some osteoarthritic change. But really, if we have a look at her back, the lumbar spine looks good. Hips look good. She's got a little bit of degenerative change maybe with the mid-upper thoracic spine, but certainly nothing that would explain why she's got a right-sided hip pain. So we go to her SPECT-CT, and we have a look. This is the left and the right-sided facet joints. So we can see here on her SPECT-CT that she's got normal physiologic uptake in her facets, normal physiologic uptake at her end plates. There's no loss of vertebral body height to suggest that she's got a fracture or any underlying sort of insufficiency or trauma post her fall in 2022. But what we can see is that she's got quite marked uptake in that relation to that right sacroiliac joint, and she's got a little bit of uptake in the superior margins of her hips bilaterally. And if you have a look at on her CT, she had narrowing of those superior joint space margins. So here we have a cause for her, you know, probably more acute right-sided hip pain related to the inflammation and uptake within that sacroiliac joint on a background of degenerative change. But if we go back to even knowing that and we go back to her planar imaging, you can see there's no way that we would have been able to tease that out. And if we'd only done the planar imaging, her hips and her back would have been reported as normal. That's my last case. So to sum it up, SPECT-CT combines the best aspects of our two modalities to answer your clinical questions. It is easy to easy for the patient to tolerate and simple to perform. It improves patients' outcomes in terms of being able to better localise sites of disease and tease out pain generators. It lowers false negative rates. Most importantly for our patients, it does not increase the out-of-pocket cost to the patient, and the additional radiation dose is minimal compared to the sort of dose of the bone scan itself.